Emergency medicine is defined as
emergency medicine is a medical specialty concerned with the care of illness or injuries requiring immediate medical attention,
which means emergency physicians are
primarily responsible for initiating resuscitation and stabilization and performing the initial investigations and interventions necessary to diagnose and treat illnesses or injuries in the acute phase. That's our commitment, 24/7, 365. We show up.
And in the process, treating injury as disease.
It's not an accident, not some random act of God. It is a true disease process that lends itself to scientific investigation.
Discover 7 decades of emergency medicine and injury prevention and control inside this edition of CTSI Discovery Radio. Welcome to CTSI Discovery Radio. I'm your host, Brian Belmer. CTSI Discovery Radio is brought to you by the Clinical and Translational Science Institute of Southeast Wisconsin. The CTSI is a consortium of researchers, doctors, scientists, and others representing 8 institutions, including the Medical College of Wisconsin, Milwaukee School of Engineering, Marquette University, the University of Wisconsin-Milwaukee, Children's Wisconsin, Freighert Hospital, Versity Blood Center of Wisconsin, and the Zablocki VA Medical Center. The CTSI works collaboratively across all of our member institutions. Our mission is advancing health through research and discovery. Emergency medicine is specialized immediate critical care for patients of all ages, often related to injuries that are preventable. Dr. Stephen Hargarten is professor of emergency medicine, founding director of the Comprehensive Injury Center, senior science and policy advisor, and founding associate dean for global health at the Medical College of Wisconsin. Last fall, Dr. Hargarten presented a Dr. Tom P. Ofterheide endowed lecture titled Emergency Medicine, Injury Prevention and Control, Reflections on Leadership and Science Spanning 7 Decades. Today, we discover portions of Dr. Hargarten's lecture, beginning with a brief outline of his presentation.
I'm going to talk about some history of luck, serendipity, and synchronicity, some definitions. I want to talk about decades of growth in emergency medicine and injury prevention and control, challenges and opportunities for us and the injury sciences in the decades, and ending with some notes and quotes.
And with that, he begins his presentation with
some personal historic notes. When I was in medical school a long time ago in the 70s, peptic ulcer disease was ravaging people. The board-like abdomen was a classic physical finding for the ruptured peptic ulcer. And the therapy for peptic ulcer disease was a partial gastrectomy. I witnessed it by a general surgeon, taking out part of the stomach for treatment of peptic ulcer disease.
Whereas today, that same peptic ulcer would be treated quite differently.
It's amazing now when Bruce Springsteen cancels his concert series, he's going to be taking an antibiotic. It's an amazing change over these decades.
Or another example of changes he's seen.
I saw cases of epiglottitis in children. It's one of the scariest moments that one can clinically have with this child who will stop breathing at any second.
Today, epiglottitis, an inflammatory condition of the upper airway, is far less concerning. In fact,
it's gone. Vaccines have taken care of that. It's an amazing development.
As mentioned, Dr. Hargarten's entry into the world of emergency medicine involved an element of good fortune.
A little bit more about my career, just as background. I did my internship at Gorgas. It was my second choice. My first choice was Gunderson in La Crosse. And I didn't know what I wanted to do in medical school. I had thought about psychiatry and said, no, that's not going to be for me. So I did a rotating internship, and the luck that I had in going to Gorgas was 2 interns ran the emergency department. The residents were upstairs. The faculty were at home. It's not a good way to run an emergency department, but I learned a ton, and I loved it. And so it was transformative for me as an emergency physician. I left that internship and started practicing emergency medicine here in Wisconsin, and I've never looked back.
Around this same time, he discovered another area of interest, public health.
It was during those years that I also helped establish a community health center. I volunteered at a refugee camp in Thailand, and I started thinking, I really like this public health stuff. So I applied to Hopkins for an international health experience because it was one of the best international health public health schools in the world.
Going there changed the arc of his career because when he got there,
I met two iconic emerging leaders in injury prevention and control, Susan Baker and Steve Terrett. And Steve Terrett became a lifelong mentor and friend of mine, and he really influenced my career heavily.
And this is where serendipity and synchronicity factored into his career path.
It was serendipity that I got to a place that was growing injury prevention and control. Left Hopkins, joined a private practice, thinking I could combine academics and community. Didn't work out.
But it did lead him to the Medical College of Wisconsin.
And joined the faculty in 1989. And it was that serendipity and synchronicity, meeting Joe Darren, being hired on a handshake, and meeting leaders like Dr. Pintar, who had a lab investigating car crashes, really an iconic research lab for the investigation of injuries in general. So from this point in time, in terms of my career trajectory, you never know where you're going to be going and what path you're going to take.
Discover more about Dr. Frank Pintar and his monumental research at the MCW Crash Lab by going back and listening to episode number 38 of our show. Next, Dr. Hargarten shares some experiences shaping his early work in injury prevention and control research.
In my time at Hopkins, I had to do a research project. So I did a research project on deaths of Peace Corps volunteers. They were young, typically, so the hypothesis was maybe dying from injury. And so I went to Peace Corps' medical director and got permission to investigate those deaths, produced a descriptive epidemiology, my first taste of academics, and notably found most of the deaths are due to injury.
Of the Peace Corps worker deaths he reviewed as part of his research, he recalls one in particular.
I reviewed the death of a Peace Corps volunteer who died from rabies. And in the record is her diary, worried about the dog having rabies, but she felt she was protected by the vaccine. And I have the doctor's notes saying all of the classic symptoms of rabies, but it can't be rabies because she's vaccinated. And it turned out the vaccine was not working.
From this early research experience, he learned then, as is still true today,
you follow the data. Every time I opened up the chart of the Peace Corps volunteer, it was a record. Death of a U.S. citizen abroad. I said, where is that record kept? U.S. Passport Office. I called the U.S. Passport Office. I said, can I look at these records? She said, well, they're probably dying the same things that are dying in the United States. I said, yeah, I know, but can we review it? And it resulted in subsequent publications, which resulted in a recent scoping analysis we just completed a year ago.
That same early research also resulted in
a mother contacting me in the mid-90s whose son, a medical student, died in a bus crash in Turkey. And she started an organization called Association for Safe International Road Travel. And I was on the board of that advocacy group for 20 years. So you never know where that research may take you, but it was a lesson learned that I've never forgotten.
And it showed him how solid research can lead to policy change.
The single most common cause of death and the highest risk of that death analysis that I performed was motorcycle crashes. So Peace Corps leaders said, all right, you got to wear a helmet. Several years later, no more motorcycle riding for Peace Corps volunteers. But that's the history and the first policy change. Very gratifying for me to be able to do that with what was really a pretty simple descriptive analysis.
Something else profoundly influencing Dr. Hargarten's career is known as the Riverbank Parable, which he shared with the precursor.
Medicine sometimes feels like this. Think about Friday night at Children's or Friday night at Freighter.
The Riverbank Parable goes like this.
There I am standing by the shore of a swiftly flowing river, and I hear the cry of a drowning man. So I jump into the river, put my arms around him, pull him to shore, and apply artificial respiration. Just when he begins to breathe, there's another cry for help. So I jump into the river, reach him, pull him to shore, apply artificial respiration. And just as he begins to breathe, another cry for help. So back in the river again, reaching, pulling, applying, breathing, and then another yell. Again and again, without end, goes the sequence. I am so busy jumping in, pulling them to shore, and applying artificial respiration that I have no time to see who the hell is upstream pushing them all in. And we'll talk about going upstream.
Next, in providing context, Dr. Hargarten provides some key definitions because, as he says,
the disease model has evolved. So we've learned a lot and we've progressed a lot with the disease process. If you're interested in learning more about this, there's a great book called The Remedy. And it's the story of Robert Koch and his investigation of trying to find a remedy for tuberculosis, the leading killer in the United States. You need a cause, you need etiology, and then you have a mechanism for its development. So there's mechanism for development, and then there's structural alterations to induce cellular changes, morphological changes, and then you have functional consequences, the clinical significance of this disease.
But that's not how doctors yet viewed medicine back in the 1800s. And so, for example, with
malaria. Malaria is Italian for bad air. Some of the investigations on malaria were done at Gorgas Hospital at the turn of the 1900s. At Gorgas, with yellow fever being rampant, they put coasters of water on the four posts of the bed. They didn't want ants crawling up the bed.
However, today, we know that malaria is
carried by a mosquito, not bad air. If there's water there, it's a breeding ground for mosquitoes. So understanding the science, the etiology was so important.
And determining the cause of disease to treat disease remains equally important today. And not just biological disease, because
the discussion here is injury prevention and control. It's caused by physical agents like kinetic energy. You can't see it. That's why we need Dr. Pintar and his group to have us see what's going on with this disease process. We have chemical injuries, overdoses like fentanyl, radiation, thermal, and electric energy. And the other causes that are emerging now, excessive heat.
Which is why it's critical to approach the conversation on injury prevention and control
in the context of a disease process. And it hasn't always been that way. So in this disease process we're going to focus on primarily with cars and bullets, falls from heights, is kinetic energy. Most injuries are caused from kinetic energy. The pathogenesis is the acute exposure of that kinetic energy in milliseconds.
He further defines, because of our body's cells' inability to absorb that kinetic energy,
it results in changes in cells and tissue tearing and edema, bleeding, and there's clinical significance that we see in the emergency department in the riverbank. Fractures, hemorrhage, subdural hematomas, and patients die. It's a disease process.
So, framing injury as disease
opens up opportunities for investigation. If the disease process is evident, then injuries are predictable. That lends to prevention, primary, secondary, and tertiary.
Furthermore, framing and treating injury as disease is crucial because
it's not an accident, not some random act of God. It is a true disease process that lends itself to scientific investigation.
In emphasizing his definition of injury as disease, Dr. Hargarten draws upon a quote from Hippocrates, Greek physician and father of modern medicine.
Of those who are wounded by a fall, he who falls from a very high place upon a very hard and blunt object is in most danger of sustaining a fracture and contusion of the bone. Whereas he that falls upon more level ground and upon a softer object is likely to suffer less injury in the bone or may not be injured at all. That's injury prevention and control. And he nailed it.
A couple more definitions. One for emergency medicine.
Emergency medicine is a medical specialty concerned with the care of illness or injuries requiring immediate medical attention. I opened up Rosen's. There was no definition of emergency medicine in the preface, so I had to go to Wikipedia, an authoritative source.
And one for first-line providers.
They are primarily responsible for initiating resuscitation and stabilization and performing the initial investigations and interventions necessary to diagnose and treat illnesses or injuries in the acute phase. We are at the riverbank. That's our commitment, 24/7, 365. We show up.
Next, Dr. Hargarten shares insights on decades of growth in emergency medicine and injury prevention and control, based on his hypothesis that
the emergence of emergency medicine specialty and the emergence of injury prevention and control science co-occurred during the same decades beginning in the 60s.
It was in the 1960s when
this really started with William Haddon. William Haddon really brought the science of epidemiology, analyses of pedestrian injuries in Manhattan, and really put the science together and codified it in a seminal textbook that was published in 1964. That really provided us with a bedrock science for injury prevention and control.
Soon after, a second book was released, this one by consumer advocate Ralph Nader, titled Unsafe at Any Speed,
which was describing the Corvair and its inherent defect in its manufacture. Driving a Corvair and you swerve to avoid another car, the wheels buckle and you roll over and you get ejected because there's no seat belts and you die. General Motors president said, well, drive more carefully.
But following these influential books, a paradigm shift was underway.
Culminating with this National Academy of Sciences, National Research Council's seminal document on accidental death and disability, the disease of modern society, focusing primarily on car crashes. And in that document were several recommendations really started to stimulate the development of emergency care, which is part of injury prevention and control. And that document was a huge effect that resulted in this eventually starting at the National Highway Traffic Safety Administration, and the first director of that was William Haddon.
Which brings us to the 1970s, and Dr. Hargarten shares a few highlights.
1971, first emergency medicine residency, Cincinnati. 1972, the Haddon Matrix, where you want to dissect this event that takes place so quickly. So you've got the prevention, pre-event, you've got the intervention. Can you do something while the energy is being transferred to the human? And then you've got the post-event, patient-host. Here's the method, kinetic energy, agent, car, physical and social environment. Here's where we sit, post-care in that environment. But you've got all these areas to investigate as emergency physicians going upstream.
And perspectives on the state of emergency medicine and injury prevention and control in the 1970s in our community.
In 1973, there was an EMS Act that provided funds for local communities to develop emergency medical services. Enter our previous chair, Dr. Darren. When I started my practice at St. Joe's Hospital in 1976, the emergency care services in the city of Milwaukee were provided by the police, because they had a van where you can lay somebody on their side. Police, 1977. And we've changed considerably because of visionaries like Joe Darren.
Dr. Joe Darren was founder of the Milwaukee County Paramedic Program in 1973 and established one of the very first emergency medicine residency programs in 1978.
Taking care of injured patients in the 60s, early 70s, and I go, oh, listen, this is not working. We need trained people in the community, Med 1, Med 2, West Dallas, and Wauwatosa, with funding from the federal government. That was his vision. And then he was so interesting and smart about it. He says, we've got these paramedics now taking care of the injured patient properly, and they go to the emergency department, and it's a complete chaotic place. Nobody knows what to do. They got interns who don't know what they're supposed to be doing, run by maybe a fellow in pulmonary medicine. Is that the way to run an emergency department? No. Start a residency program. So that's what he did.
Finally, from the 70s, he shares a quote from Dr. Francis Moore, one of the great surgical scientists of the 20th century.
Responsibilities of physicians. Internal medicine and pediatrics have taken progressively wider views in their areas of social responsibility, the one reaching deeply into physiology and biochemistry, and the other branching out in the field of genetics and prenatal diagnosis. For the study of trauma, surgery, and I've added emergency medicine, must likewise broaden their focus to include social, environmental, political disciplines that have not formally been considered a concern of the trauma physician. And if surgery, emergency medicine, fails to broaden their scope and social vision, their future will be stunted and our understanding of trauma will be faulty. That quote has taken me throughout my career because that's where we need to be. At the riverbank, many of us going upstream, finding out what the hell's going on.
On to the 1980s and 90s, as the evolution of emergency medicine and injury prevention and control science increases.
We get into the 80s. The disease model for injury prevention and control is advancing. Emergency medicine as a specialty is advancing. Injury in America, 1985, stimulated by monies from the Department of Transportation, outlining we got a problem here. We need to do something about it. And that resulted in other red books being published. CDC leadership funding research centers around the United States. There were 5 initially. One of them was from Iowa. They needed biomechanical support for their research proposal, and they engaged Dr. Pintar and his group to do studies on injury prevention and control. So medical college is now linked with these centers back in the 1980s.
This period of rapid growth brought about many significant and necessary changes.
So common functions of EMS, injury prevention programs, are integrated into the fabric of EMS. Dr. Darren was the first Wisconsin medical director for EMS in its history.
And emergency medicine physicians were given expanded roles based on their expertise.
The rise of emergency medicine leadership in toxicology. It used to be a pediatrician was in charge of toxicology, and now it's run by emergency physicians. And we see that now with the director of the Children's Hospital Poison Center being an emergency physician.
Including at the national level,
Rick Martinez, emergency physician, became the first emergency physician to run NHTSA.
NHTSA is the National Highway Traffic Safety Administration. It was during this time MCW kick-started the evolution of the National Violent Death Reporting System.
So the evolution of violent death reporting system began here in Milwaukee County, patterned after the fatal analysis reporting system of NHTSA. NHTSA has been accounting for deaths from car crashes since 1975, combining information from medical examiners, coroners, making sure that we understand the distribution of those deaths, including the cars that were implicated in those deaths. There's linking information to strengthen our understanding of violent deaths, homicides, and suicides. We worked with the medical examiner, the police, the crime lab. All those helped us get that information linked. The pilot work began in the city of Milwaukee, the county of Milwaukee, southeastern Wisconsin, and then the entire state through foundation funding. And this pilot work led to further funding, which finally led to the national system of CDC's violent death reporting system. It's very gratifying to see how this initial work that we did was thoughtfully replicated and really embraced by the CDC.
And growth was reflected in rapidly expanding numbers of emergency and injury prevention and control departments.
Academic departments in 1990, there were only 15. Now there's 80 to 90. This has been a growth spurt in emergency medicine.
Dr. Hargarten also shared MCW's impact on what he referred to as the Black Talon story.
It's a hollow point bullet that opens up upon impact with the patient and exposes razor-sharp talons. It was started by the FBI wanting a better bullet to combat bad guys, but we didn't want this in the civilian market. Our trauma surgeons, this represents a danger when she's trying to figure out where the bleeding source is, cuts her finger on this razor-sharp talon, and exposes herself to HIV and hepatitis. We thought this was an unacceptable virus being introduced in a commercial environment. It was picked up by the media because we sent this bullet to 20 congressional leaders, and pretty soon there was legislation being introduced to ban the manufacture of this bullet. That's what happened in the 1990s with this Black Talon story that emanated from an office in the Department of Emergency Medicine back in 1995.
And he says the science of emergency medicine continued making headlines.
Publications on this science field started to emerge in the emergency medicine literature that many of us had a chance to publish in. It was exponentially changing and taking off in the 90s and beyond.
Which brings us through the 2000s to today, when emergency physicians now hold leadership positions across academia.
Rebecca Cunningham is an emergency physician who ran an injury research center at the University of Michigan. She is now in charge of all of the research at the University of Michigan. And you got Megan Rainey. She became very interested in injury prevention and control. She's now the dean of the School of Public Health at a small university out east. I think it's Yale.
As well as at the federal level and across the globe.
Jeff Runge, another emergency physician, became NHTSA's director and the second emergency physician to run that agency. Deb Howry did work on domestic violence, intimate partner violence at Emory University, and is now second in command of all science at the CDC. And finally, Terry Reynolds, she was involved in the development of emergency medicine in Tanzania. And, oh, that's right, she's in charge of trauma care systems and injury prevention and control at that small organization, WHO.
Another key to the success and future success of injury prevention and control: collaboration through team science.
It's really important to see how this is broadened and applicable to our specialty in emergency medicine, and brings in our colleagues in engineering and other elements of what brings us to the prevention phase. You can't say enough about our partners in trauma surgery. They're showing up at the riverbank too, and they're the ones who've helped us in improving acute care.
And another example of collaboration.
When I first joined the faculty, I was taking care of a patient with a hand injury, and some research person comes in and starts asking the question about post-traumatic stress flashbacks. I said, what's going on here? I said, yeah, we're doing a study on hand injuries and flashbacks and the development or risk of post-traumatic stress disorder. And so interesting that rehabilitation phase began in the emergency department.
this is more applicable today than ever.
With Terry DeRune-Cassini leading the Comprehensive Injury Center, she's a psychologist, an expert at post-traumatic stress, and now we have a combined clinic taking care of gunshot wound victims, not only for their biological injury, a bullet wound, but they're concerned about a behavioral injury or perhaps social care issue. That is bringing us to the forefront of biopsychosocial care of these patients.
Dr. Hargarten also highlighted some technological advancements impacting emergency medicine.
First of all, ultrasound and then video. In 1995, when I was interim chair, I went to the medical director of General Electric that makes ultrasound machines. I said, we really like to have ultrasound technology in the emergency department. And he looked at me as he began to throw me out of his office, saying, we only deal with radiologists. 1995.
Compared to today, when
we've got better care for patients because we have an image right away. One of the biggest areas of impact was shown by Dr. Plummer in 1992. He was in Hennepin. Detecting penetrating cardiac injury early resulted in earlier OR treatment and improved survival rate with better neurological outcomes. Ultrasound in the care of patients. That's what it's all about at the Riverbank.
As for video,
the video camera, I postulate, is the microscope of this disease. Because without being able to see it in slow motion, you don't understand what the hell's going on.
Video technology has been crucial in his research on gun violence, especially considering
it's the most common cause of death of children in the United States. It's the most common cause of death of children in Wisconsin. It's the most common cause of death of young African-American males. It's a bullet. So we need to study it.
And he has studied it extensively.
In 1995, 96, we studied this with technology at that time, which was 8,000 frames a second to maybe 19,000, as I recall, trying to capture the bullet as it went through gelatin, a human facsimile of muscle.
Compared to video technology today,
it's an amazing technology that's developed where this video camera can take 50,000 to 100,000 frames a second, trying to capture a bullet going 3,000 feet per second. It's our microscope. We understand this bullet behavior now because of this technology, and maybe identify prevention and control strategies.
Heading into the future,
we'll continue this growth together. This is just the start of an extraordinary wave of continued interest in injury prevention and control, emergency medicine across many disciplines. For the upcoming decades, I think the research is going to continue, recognizing patterns of injury and going upstream, exploring and establishing information data linkages, assaults, bicycles, pedestrian injuries, chemical injuries, and perhaps maybe there will be a National Institute of Prevention and Control.
In our community, Ground Zero is at Hargarten, the Medical College of Wisconsin, and Children's Wisconsin.
This campus is the single most busy provider of emergency services in the state. Together, these two emergency departments take care of more patients than any other place in the state of Wisconsin.
And it's here a difference can be and is being made.
When we get out of school and join the workforce, we're taught how to make a buck, not how to make a difference. And I think all of you, students, residents, faculty, other members of departments, you're going to make a difference with our patients at the Riverbank as well as in our communities. So thank you for this honor and for listening to this presentation. And remember, the world is run by those who show up. So thanks for showing up.
That wraps up this edition of CTSI Discovery Radio. We hope you enjoyed hearing portions of this special presentation, a retrospective of 7 decades, with today's guest, Dr. Stephen Hargarten. I hope you've discovered something by listening to today's show, and I'm doubly hopeful you'll join us again next time. CTSI Discovery Radio airs the 3rd Friday of every month. Make an appointment on your calendar and join us for each episode. On behalf of the Clinical and Translational Science Institute of Southeast Wisconsin and all of our affiliate partners and members, I'm Brian Belmer, wishing you happier, healthier days ahead. For more information about research or to listen to the podcast of this or any of our shows on demand, please visit our website at ctsi.mcw.edu. CTSI Discovery Radio is written, produced, and hosted by Brian Belmer in collaboration with WMSE Radio. The CTSI and this program are under the direction of Dr. Reza Shakir.